Hi, everyone. My name is Megan Gomeza, and I have the pleasure of working on the IROPES, or Idaho Rural Opioid Prevention and Pharmacy Education Stewardship Project, funded through the HRSA Rural Community Opioid Response Program. The IROPES consortium includes 5 clinics in rural areas within Idaho, seeking to increase their capacity for medications for opiate use disorder, and also offers expert consultation and enhanced training for rural providers prescribing Suboxone, as well as support to the clinic and community in deploying harm reduction strategies. Today's tapering education for benzodiazepines and opioids is part of those educational activities intended to support increased prescribing of medications for opiate use disorder. As many of you know, effectively tapering patients from opioids and benzodiazepines is an important first step in reducing risk of opioid dependence and risk of overdose. Tyler Hemsley, PharmD, and Shelby Lancaster, PharmD, will present practical strategies and tools for reducing and eliminating unnecessary benzodiazepines and opioids. Shelby Lancaster, PharmD, is a consultant to the IROPES project and also a practicing clinical and retail pharmacist in rural Shoshone, Idaho. Tyler Hemsley, PharmD, is a consultant to the IROPES project and a practicing clinical pharmacist in the St. Luke's Health System. So without any further ado, Shelby and Tyler, thank you for joining us today.
Awesome. Thank you, Megan. Appreciate the introduction and excited to be with you today to discuss some strategies as it relates to opioid and benzodiazepine tapers and conversations and strategies as we approach this, what can be a difficult topic and a difficult conversation with patients. And so hopefully you'll find some beneficial tips and tricks and kind of tools for the toolbox today. Excited to be here with Shelby, and hopefully we can make this educational and conversational. And so we just want to go through a few different objectives for today's presentation. And one of the things that we have heard in our conversations with clinics and providers is that one of the challenges in this realm is essentially how to even break the ice, how to approach these conversations around tapering. Some of the strategies that we can use with motivational interviewing in approaching those conversations and kind of gauging the readiness to change on behalf of our patients. How to express our concerns, basically letting folks know that there are some risks associated with these medications and their long-term use. They can be very effective when they're used appropriately, and we just want to be cautious if we see areas of concern. We also want to provide a support system, and we're going to discuss a few different options in terms of, you know, behavioral health resources and pharmacy resources, community resources, essentially putting a support system around a patient as they're ready to engage and make sure that they have those resources around them when they're ready. We'll also dive into a little bit of detail specifically on the tapering strategy, the dosing, the calculations, and how to set appropriate expectations for the patients. And then just making sure that we're giving the patients as much information as possible and arming them with the appropriate resources. So I'll kind of kick it over to Shelby at this point, talking first, just opening up the conversation on that first objective. But maybe if you could discuss in your experience a little bit more about how we approach these conversations and some of the strategies that you've seen to be effective in your clinical practice.
Yeah, thank you, Tyler. So some of the things that I have found that's been very helpful is utilizing a patient-centered approach and being able to assess where the patient's at. But essentially, a lot of the information that I have devised or have come across that's been very helpful is from the patient-centered opioid tapering webinar that was presented by Beth Darnell. She's a PhD and associate professor at Stanford University School of Medicine, and Aram Mardian, an MD clinical associate professor at the University of Arizona College of Medicine in Phoenix. So like Tyler mentioned, that these conversations can be very difficult, not only for the patient, but also for the provider. And as we've found, it's been quite uncommon for patients to approach us as providers and want to taper their opioids or their benzodiazepines. So sometimes this conversation can evoke some anger and frustration with the patient, as well as the discomfort with the provider. So some of the things that we found that have been helpful are using diffusion techniques by finding compassionate ways of labeling the emotional experience that the patient is having and being able to validate that experience. So some of the examples that I would use is saying, it seems as if you may be angry or upset with this situation, or I understand why you would be fearful or angry regarding a taper of these medications. Basically, framing it in that way helps the patient feel heard and that you understand that this is going to be a difficult process for them. So one of the things that isn't the easiest, but also is very important, is utilizing those motivational interviewing skills. It's pertinent to developing a relationship with a patient in order to discuss and attempt a dose reduction with either of these classes of medications, because these patients have been on these medications for years in some instances and can be very resistant to change and afraid of change. So being able to frame it in that mind so they understand where you're coming from and understand that the hesitancy with regards to that tapering.
I think that's super important to call out, is in the importance of a patient feeling that they're heard, that it's not just a situation that is being imposed upon them, and that a lot of times, I mean, I think it's important to acknowledge that it's been recently that this new evidence has come out, and the new recommendations from the CDC around opioid prescribing and not concomitant, not using benzodiazepines in a concomitant approach, and some of the dangers and risks that we have in long-term opioid use. It wasn't so long ago that we had, pain is the fifth vital sign, and we had this long-term approach to opioids as kind of a standard of practice in terms of chronic pain control. And so I think you're absolutely right that these are patients who may have been on a specific regimen of medication for years, and this is what they've become accustomed to, and this is how they're actually functioning in their life. And so approaching these situations and understanding that this is a disruption, there probably is going to be some hesitancy. I read a really interesting study a while back from some providers and patients in Australia that, it was all about the perception of medication, and a lot of times from a patient's perception, these medications serve as their protection against either pain or the impact of the disease. And if we're ever thinking about deprescribing or tapering, it's almost as though we could imagine we're peeling elements of their armor away, right? And so I think we need to validate those concerns. We need to approach this as a collaborative effort, set some appropriate expectations, but also from the perspective of the providers being able to validly express their concerns, right? And so I think that might segue into our next topic, but kind of being able to assess and express from a provider's perspective, and if you have any tips and tricks kind of from the perspective of the prescriber or potentially as a member of the care team.
Yes, definitely. So the VA has actually done a really good job of outlining some of these conversations that they found to be very effective in their practice. So when you're assessing these patients and their risks and their benefits, you are able to express your concerns and provide education to the patient. So you could say, as you are assessing the risks and the benefits of continuing that therapy, I'd like to take a minute to discuss my concerns about this specific medication, whether it be opioids or benzodiazepines, and follow up with, with these benzodiazepines, there's a risk of falls and cognitive decline. But we could look at the discontinuation benefits, and we may see an improvement in your anxiety, your depression, your insomnia, and your thought process. So it's important to look at not only the risks where we drive those home, and I think the patients get that a lot, but they don't necessarily always see the benefits to peeling these therapies away. In the instances of opioids, saying, I haven't really seen an improvement in your pain or function with the continued use of this, or even with a recent dose increase. So we could look at the benefits of discontinuation, such as potential reduction in pain, increased clarity of thinking, and decreased drowsiness, kind of citing some of those side effects that you can have with opioids. But being able to provide non-judgmental education about opioids or benzodiazepines, and talking about the tapering process. So we can express our concerns with regards to those therapies, and then also assess their readiness and their concerns with tapering. So using your motivational interviewing skills here and asking those open-ended questions of, what do you see as the possible benefits of stopping or reducing this dose? What concerns do you have with reducing this dose or stopping the medication? And what can we do together to help address some of these concerns? So being able to open those conversations up with the patient, so that way you can really have a one-on-one discussion of how they feel, how important they feel like this medication is to them. Some of the other things too that can be helpful is providing some educational handouts, or giving them a list of trusted websites that can be visited, especially if they seem resistant. Also educating about the importance of those appropriate sources, so that way they're getting evidence-based information. Some of these sources could be about tolerance or dependence or addiction, can talk about withdrawal symptoms and how they can be treated, benefits of stopping some of these medications. And hopefully that will give them some insight into what we're seeing as providers, and how we can help them not depend on these medications lifelong.
Absolutely agree. I think there's really significant points that you make there, just in terms of assessing their readiness to change, kind of drawing out and maybe even challenging some of their own perceptions about the medication, and even just presenting an alternative perspective of, or submitting the possibility that life could actually get better if we decrease this dose, and you could, essentially be having less pain, because we know that there's situations where people have developed, that hyperalgesia state, and if we approach this effectively, they could actually return to, a lower baseline threshold, for pain. So I think you brought up a really good point about arming the patient essentially with good resources. And I think that might be kind of leading into our next discussion. But what I think of this as surrounding the patient with all of the support that they need. And sometimes that's educational resources, sometimes that's other members of the care team, whether it's behavioral health, or whether it's, pharmacy and education from the pharmaceutical perspective, to say, this is how this medication is working. These are, kind of we can even dive into the kinetics, because I think it's important that they realize what our strategy is as we approach the taper, kind of understanding the current dosing, the current total exposure, and how we're going to add all that up and make sure that we're not just stripping this away in kind of a cold turkey systematic drawdown, because that can be incredibly off-putting and scary for a patient if they feel like they're just going to rip this away from me, rather than work with me as we figure out how my dose is going to come down, how I manage my symptoms, how we can maybe slow down at certain points if we need to. But can you talk a little bit about the importance of supportive therapy and making sure that patients have a good strategy in their mind as we approach the taper?
Definitely. So a lot of these patients have they have underlying and contributing comorbidities that sometimes get ignored as we're looking at treating pain, that fifth vital sign, saying that essentially we need to be able to look at some other therapies to help treat these comorbidities and potentially reduce their pain in that manner. So just kind of circling back to some of these motivational interviewing questions, one of the things that I find that's helpful is asking, what changes are you willing to make to help meet this goal if they've decided that this is something that they want to move forward with? Or, would you be willing to talk to one of my colleagues to learn about options to support your changes? And that's just what Tyler was saying, is talking to someone from the behavioral health team, a behavioral health team member, or a pharmaceutical team member. But outside of that, being able to show them that there are options. So looking at some multimodal treatment therapies, including some pharmacotherapy, but ensuring that as you're discussing some alternatives that can be used for pain, you just want to set the expectation that you're not going to be replacing their opioid with another medication, because medications can only do so much, only improve function so much before they start causing side effects or other issues that come along with it. But saying that there are some things that we can do to help support them in that manner. But looking at some of our other team members, engaging that behavioral health specialist, kind of selling the behavioral health realm, saying that these individuals are key to helping us develop skills to self-manage their pain at home. If there isn't a BH individual that's within your clinical setting, there are some free resources online that could potentially be helpful if the patient's motivated enough to develop these skills. But one thing I found that was actually really cool, that helps kind of give a bit of perspective from a behavioral health component there, that there are 8,736 hours in the year. And in an average chronic pain patient, the provider may see them for 20 to 30 minutes, maybe an hour if they're absolutely lucky, every 3 months. And this is about 2 to 4 hours that you as the provider are helping them manage their pain and their chronic pain each year. So there are 8,732 hours that them as a patient are managing their chronic pain at home, and ensuring that they have the tools in their toolbox to be able to get through those times is important. And these resources that I mentioned can be helpful to develop some of those tools. Another team member that we maybe haven't mentioned as of yet, but could very, very well be a key to this plan, is like a chronic care manager or a nursing staff that is really involved with patient care, being able to maybe assign these patients to that care team member. So that way, if the patient is having some issues and needs some support, they can reach out to them directly saying, hey, I'm having these problems. Being able to allow someone that can triage them if any of these issues that they're having come up. This could require some training and understanding, but essentially this individual on your team could be very, very helpful. It doesn't have to necessarily be a chronic care manager, but like I said, the medical assistant that has appropriate training or that you feel is capable of this task can be very, very helpful. Following up with some other pharmacological treatment therapies, being able to let the patient know that, yes, this can be a difficult time. There's things that can happen in the sense that we can have withdrawal symptoms if it's not done slowly enough, but we'll do what we can to help prevent it. But know that there are therapies that can help decrease some of the symptoms that they're having from withdrawal, excuse me. So another point on this is educating them, telling them that withdrawal is only temporary and not all patients have symptoms, but helping them understand that we will work together as a team to be able to have a slow taper to reduce the risk for these symptoms of developing. And that we could also, like Tyler said, look at adjusting the tapering rate, doing a slower taper during a certain period of time to help slow those symptoms or reduce them. And then also some of the other things that we could look at is treating their depression, treating their anxiety and insomnia, because one of the things I found that was actually quite interesting is that there's data to support that individuals who have higher depression scores before starting a taper actually have a lower likelihood of succeeding with that taper. So ensuring that these comorbidities are treated appropriately is very important.
I think that's a very important point. From the perspective of developing a plan. And from my experience, I kind of go back to when I was working in a cancer center, and the pharmacists were in charge of essentially developing and managing the plan to control for chemo-induced nausea and vomiting. And before anyone started on therapy, there was an extensive interview. We talked about their concerns. We talked about, previous history in terms of chemical exposure, so that certain things would raise your risk or certain things would lower your risk if you've been exposed to more kind of toxic chemicals in the past, whether that be through smoking or substance use or occupational exposure, those sorts of things. We took all of those things into account, and as well as kind of the risk factors or the concerns from the patient themselves, right? Because so much of it is psychological as well, and how they perceived or what kind of concerns they had, and just acknowledging fears, acknowledging concerns, and making sure that we've got these supportive therapies and we've got this plan in place. And I think it's great you call out the idea of a care manager, kind of that point person to help triage things. That's one of the changes that I've seen in healthcare over the last few years, where there has been an increased emphasis on preventive and proactive outreach to patients, so that we're touching base for these brief interventions, but more often, and making sure that maybe it is just a 15-minute check-in, but we're touching base, we're making sure that they have the support that they need, and making sure that they're not feeling like they're out there on their own trying to deal with this by themselves. So some great points.
Well, I think that we've touched on a lot of the supportive therapy and kind of the conversation that leads up to the actual tapering process. Now, I think we're ready to go ahead and dive into that. So with this, I found that it's quite interesting, but there's some data to support that the more involvement that the patient has with their taper, the more success that they will have. So it's important to consider asking the patient that if they were to develop their own tapering plan, what would it look like? So that way you could get an understanding of where the patient's at and where they would like to be, and also taking into account some of their fears and frustrations with a process like this. Also, it's important to remember that even though we assume the ultimate goal is to taper to zero, less opioids and less benzodiazepines is also an achievement to behold. So reminding ourselves that not getting down to zero does not mean a failure. And also reminding the patient, if you have a highly motivated patient that wants to get off of these medications, that also that is not considered a failure if we have to pause the taper or increase the dose slightly to a higher dose at one point in time that's better tolerated, so that we can hold off and pause and then be able to restart it. It's also important to reinforce that these tapers may take weeks to months in order for us to taper them slowly enough so they don't have as many side effects or withdrawal symptoms. And one of the other things too that we could consider is prescribing a withdrawal cocktail that will preemptively help with some of these withdrawal symptoms, so the patient knows that they could go to these medications if they have any issues. So I'll go ahead and show the tapering quick tips document that we had put together. Essentially with this, the top part is the opioids and the bottom part is the benzodiazepines. We pulled pretty much all of this data from the VA guidelines for the opioid and benzodiazepine tapers. And there was also a really great resource called the Pain Treatment Guidelines from the Oregon Pain Guidance and Columbia Pacific CCO that was really helpful in developing these. So essentially, the top part here just specifies that once the patient is on board with this taper, that we need to assess their type of their opioid and their stability to be able to look at the selection of which rate we want to go with. So with longer acting opioids or more stable patients, we can do a 20 to 40% dose reduction each month of that total daily dose. But if they're short acting opioids or a less stable patient that we need to get them off the medications a little bit quicker, we can do a more aggressive tapering strategy. But essentially looking at reasonable start dates and potential completion dates, really stressing that it could take months for this to occur, and again, providing those behavioral supports that we mentioned. One of the other things that we didn't mention was also talking about overdose risk. Even if the patient hasn't had any of these issues in the past, it's one thing that we want to make sure is addressed, and looking at potentially prescribing some naloxone to help support them if something were to happen. We also want to make sure that we're touching base with these patients frequently, and Tyler did stress that, but every single time we do a dose change, doing a follow-up in days or 1 week is very helpful, but making sure that we have those touch points scheduled and that expectation there that we are here for them. If you wanted to, you could even use adherence checks like urine drug screens to make sure that the patient is taking what they're supposed to be taking. You could look at pill counts, you can check the PDMP, and you could even do some short fills to get them do a week at a time if you have a patient that's struggling to stay engaged. You could do a week at a time or a couple weeks at a time, what have you. And then also discuss, of course, those expectations and symptoms of withdrawal, being able to provide those options there. One other thing that I just want to make sure that is noted is that once you reach 25 to 50% of that initial dose for these opioids, you could potentially consider slowing the taper, so that way we can help reduce the risk for opioid withdrawal to occur, especially if these patients have been really engaged and have been motivated to help with this reduction. But again, it's very important to remember that 0 may not be reasonable for the patient, but reduced dosing is still a feat to behold there.
I also think it's important to call out that 0 pain is not a reasonable goal, right? And I think that was something that from years ago when we talked about setting goals with the patients, and no pain was one of the things that we talked about. And I think we did ourselves a little bit of a disservice there. Pain can actually be a valuable thing in the body, to let us know, if we're overdoing it, or if we can tolerate a certain amount of pain, that actually is a reasonable goal. And so I think it's just important to reemphasize as we consider both the tapering pace as well as the strategy, and developing that strategy with the patient, and whether they think, maybe some short fills, maybe if I just needed to have a 2 weeks supply of medication, and then I know I'm going to come back and I'm going to check in, then maybe that's a really good strategy, and it's going to help them feel more engaged with the plan. And they've got all those supportive medications at their disposal to be able to make sure, you know, that they've got those, especially the symptomatic management. You know, obviously antidepressants aren't going to be like a quick as needed thing, but you know, some of the GI medications or you know, things like that are going to be important to have at your disposal. So, you know, I think that's really good, and I like the idea again of, you know, we're starting and tapering that initial, you know, 25 to 50%, but especially reassessing and maybe, you know, gliding out the rest of that taper, so that we can try to, you know, assess withdrawal symptoms and make sure that we can work with the patient and pace as appropriate.
Definitely, definitely. And there was something that I wanted to mention here, that I found interesting as I was reviewing that patient-centered opioid tapering webinar that I mentioned first thing in the presentation. But tapering isn't for everyone. And when I mean that, it's basically those patients that you identify struggling with opioid use disorder. The evidence supports that an individual struggling with this benefits most from referral into a substance use disorder program and transitioning to a buprenorphine regimen. We don't really have any time to talk too much about that today, but it is something that we need to ensure that we're another support system for our patients, that if we identify that this is happening, that we get them to the right individual, and ensuring to talk to them about opioid use disorder as a chronic disease, and that there's stigma that surrounds that, and hopefully we can reduce that stigma by addressing it and talking to our patients and getting them into the evidence-based treatment
That's a good point.
programs. So yeah. So the next thing that we'll talk about is the benzodiazepines, which is the second portion of that tapering quick tips PDF that you have. So it's very similar to the opioid tapering portion, at least the top part here. So this one could take a little bit longer. And one of the things that I came across in my research is that if you have an individual that's on both opioids and benzodiazepines, that trying to taper the opioid first is ideal, just because we can do that a little bit more quickly compared to the benzodiazepines. So again, with this, the setting those reasonable start and completion dates, setting up those expectations for how long this could possibly take. One of the things that does differ here is that it might be helpful to switch over to a longer acting benzodiazepine prior to the taper initiation, just because patients can potentially tolerate the taper a little bit better since we have a longer acting benzodiazepine on board. So what they do recommend is doing an initial dose reduction of 25 to 50% to help reduce the risk of side effects or having too high of a dose initially. But again, having those frequent follow-ups, doing days after the initial conversion to ensure that it's the appropriate dose, and then doing those 1 to 4 week follow-ups with each dose reduction. You can use those adherence checks that were mentioned in the opioid tapering, and then also discussing those expectations of symptom withdrawal. We did line out here the equivalence between the intermediate acting and the long acting benzodiazepines. So a calculation could be done quite simply with that document there in front of you. And then looking at a shorter taper versus a longer taper, depending upon risk factors of the patient, as well as the discussion that you have with that patient, being able to look at either a 20 to 40% dose reduction each month, or a 10 to 20% dose reduction each month, which you could basically on either of these prescribe the lowest strength dose of the medication that you're prescribing, and do even half tablet dose reductions to the best of your ability, looking at these smaller dose reductions here. So this can definitely be challenging, but again, hopefully these resources that we provide for you, the tapering quick tips PDF, can be helpful. I did want to show on this last slide, we did come up with a tapering tear sheet. So with this, it does allow you to give the patient, allow the patient to take this home, so that way they know what the expectations are. So you could look at, on a weekly basis, this is what we're doing on a divided dose schedule, or on a monthly basis, this is what we're looking at. And you could do either the whole tapering schedule here, or if that seems very overwhelming for your patient, doing it on a weekly basis, and making sure that they know that there's that follow-up that's going to occur, to ensure that they feel supported and know that you are there for them. So we thought that this might be helpful, that you could do it really quickly during the visit, for the patient to be able to take home, maybe scan it into the patient's chart before they take it, so that way you guys are on the same page when the patient comes back.
And I think even though this is a fairly low tech tool, right? I mean, this is half a sheet of paper, but I've actually seen this be very, very effective in a couple of different settings. I've seen this type of a calendar or a dosing regimen be effective in something complicated like warfarin management, right? Where you're taking maybe different strength pills on different days of the week, or things like that. And it really helps to have a physical card or tear sheet that the patient knows, they know where their sheet is. They post it on the fridge, or they have it there, and they know that they can refer to it. The other thing that I've seen work really well is from an adherence perspective in cystic fibrosis. So I've got some experience in the specialty pharmacy world, and one of our pharmacists who's integrated into the cystic fibrosis clinic came up with the idea of an adherence calendar for one of her patients, and it was super successful from the perspective of a visual cue. And so it was, identifying goal dates, or, circle this week with a red pen, and this is the one that we're getting to. And it worked when nothing else did. And even in one of her pediatric patients, they like set a goal and had like a, pizza as a celebration or something on a certain date. So I think an engagement that way, that's a physical reference document for the patient, I think can be really valuable in that engagement and kind of collaboration to the approach that we've been kind of hammering on throughout this presentation. It's super, super important, and kind of speaks to the value of that behavioral component. It's not all about the perfect calculation of the dosing and the exactly 20% reduction per week, and that's how we're going to get to our goal at the end. It's not really about that. The most important thing here, I think, is working with your patients, engaging with your patients, also understanding the full clinical picture to determine, what do we really need to watch out for? Is it more of the pain that's going to creep back in? Is it more of the anxiety or depression that's going to creep back in? And how do we develop a plan to help this patient reach their goal that we can decide on together? So I think some really excellent points. The only other thing that I thought about mentioning, just if we could go back one slide in terms of the dosing reduction and kind of the strategy, from a pharmacological perspective, I think it's important to call out the goal of kind of swapping to a longer acting benzodiazepine. And essentially, I think what tends to make sense to patients is what we're going for here is a smoother kind of a glide path rather than peaks and troughs, right? And so if you put a longer acting agent dosed multiple times throughout a day, then you're getting a much smoother kinetic profile rather than, the spikes and troughs that we see in something like an alprazolam. So that, in a lot of these cases, it's that psychological validation that I just took something and that produces the desired effect. And that's what we're trying to kind of get away from. So again, setting those appropriate expectations with the patient and helping them understand the strategy as we move through the taper. So a lot of really excellent points. I think this is again, sometimes a challenging conversation, but I feel like hopefully these were some helpful strategies, some helpful tools that folks might find applicable in their practice. And we'll be back with more conversations throughout the course of this grant. So really appreciate the work kind of bringing this information together, and maybe we can hand the mic back over to Megan if we want to close out for this session.
Yeah.
Today's education on tapering of opioids and benzodiazepines is part of an educational activity intended to support increased prescribing of medications for opioid use disorder. This is made available to you through the IROPS, or Idaho Rural Opioid Prevention and Pharmacy Education Stewardship Project, funded through the HRSA Rural Community Opioid Response Program. For questions about this series of presentations or the IROPS project, please feel free to contact me at Megan, MEGANPG, @CHU.org for more information.